Good evening and welcome to the Longevity Lounge. I'm Dr. William Long, a physician in Charlotte, North Carolina with MD-VIP. And tonight I'm privileged to have a colleague and friend here to talk about hormone replacement in women. Tilia is a nurse practitioner. She's the founder and owner of Norris Medical Clinic in Monroe, North Carolina. Good night. Good evening.
Hey, it's a pleasure to be here.
So before we start, why did we decide to do this talk?
We decided to do this when I believe over the years working together, when we really realized the how many women were unnecessarily suffering from menopause or the symptoms related to menopause.
Yes. And I know you can relate to that on a personal level.
Yes.
Like so many of us men who live with you wonderful women that are suffering menopausal symptoms. So why, just for the audience, why had women been so reluctant in large numbers to not get treatment for this problem?
I would say out of fear. And out of fear, primarily with the concern of breast cancer. We were taught, I was taught as a provider, and I'm sure you were, that hormone replacement, estrogen, leads to breast cancer. And more recent, it's been founded to be
not true.
Not true.
Yeah, I agree. So, if you look back historically, there was a large study done about 20 some years ago. It's called the Women's Health Initiative. Had a lot of women participate, and the study was stopped early because they said it was a 28% increase in breast cancer. And as you know, that turns out that wasn't true at all.
Right.
Yeah. So, if we look at that study briefly, we don't want to dwell on this, but actually, in the estrogen alone arm, there was less breast cancer, which is kind of weird if you think about it. It was the estrogen progestin arm, and the culprit probably was medroxyprogesterone that was causing increased breast cancer.
That you do not even use today.
No, it's not no one uses it. It was Provera. And and so as it turns out, there was really one extra case per 1,000 women, but the deaths were no different. And so if we think about it, really, we didn't save a single life by not giving women hormones. What we did is made a whole bunch of people miserable.
Right.
And probably some of them died from hip fractures and osteoporosis.
Correct. Yes.
Yep. So since you're the guy that does this a lot all day long, when a patient comes in, what do you do, and how would you know that this person is appropriate for hormone replacement treatment?
So we would know. We would really know by doing labs and seeing the increase in the FSH.
Right.
However, they will have a list of symptoms that go along with the labs also, and we treat based on the symptoms as well. But the biggest thing is knowing that the levels of the FSH, the estradiol, and the.
Now, when women show up on your doorstep, what do they complain of? I know everybody uses this term vasomotor symptoms.
Right, hot flashes, not sleeping at night, cognitive issues, and that can be pretty subtle, but just very overwhelmed with how they feel in general. Lower sex drive.
Yeah, and I know. I've heard a lot of women, and one or two that are sitting close by, that complain of sweating all night. That the house so damn cold you can't stand it, right?
That is correct, yes.
Right. So I guess at the end of the day, when these people show up, you get lab and you find that they have, high FSH, which is follicle stimulating hormone. We get other labs as well. I think you would agree.
Yes, we do an extensive lab panel. So other than just the hormones, absolutely.
Now, since we were talking a little bit about vasomotor symptoms, which I think is what get a lot of women in the door, what actually is the cause of these symptoms for women? What the heck happened to them?
Well, what's happening is your ovaries are failing. They're no longer working, which is causing you to have little or no. In most cases, it's very, very little, to where it doesn't even show up on the labs.
Right.
Of estrogen. So that then causes your FSH to increase, which tells us you're in menopause.
Yeah, so essentially you got failing ovaries, rapidly decreasing estrogen levels, rapidly decreasing progesterone, and
testosterone.
That's right, the infamous testosterone.
Yes.
There you go. So now that we've talked about testosterone just a little bit, why do women even care about testosterone? I know all these women think, oh, I'm going to be all muscled up.
Right. In fact, it doesn't. It would take so much more than what we would replace to cause that. So usually what gets their attention is the hair loss or the lack of sex drive, decreased muscle mass, meaning even if they are exercising at all, you just can't build any muscle tone.
Right, and I think I hear, and I know you and I've talked about this, is, there's so much talk today about all this weight gain and getting fat, and I think a lot of women come in.
Abdominal fat's a big one. They come in
a lot of women, I can't lose weight. So I think testosterone is worth talking about, and maybe we'll talk about that in a minute. So just again to reiterate, once you make the diagnosis of menopause, what is it you actually do for the patient? Now, you say, I'm going to be a woman today, and I'm going to say, you tell me my FSH is sky high, I have no estrogen, I have no testosterone. What is the thought process, and what does the client or the patient need to know?
So the first thing we're going to do is look at replacing your estrogen to get your estrogen levels up, and your FSH will in turn come down.
Correct.
So, and you can do that through a patch, through a pill, creams, or they have pellets now that we use quite a bit in our office to replace that. You can even do oral, which I'm personally not a fan of, only because there's a slight risk of clotting. And so by not using the oral form, you're pretty much eliminating the risk for any clots.
Yeah, that makes sense.
So I typically do not use the oral.
Now, when the patient comes in, is it important if they've had a hysterectomy and their uterus removed, or they still have an intact uterus or womb? Is that important?
Yes, absolutely. If you have a uterus, we will also give you progesterone along with the estradiol. You must take it. We'll just make it easy to prevent uterine cancer. It protects the lining of your uterus.
Yes.
So yes, you will get that. If you do not have a uterus, you do not need progesterone. However, some patients still get it if they're having a lot of problems sleeping. It does help with sleep.
I've heard that progesterone is a really great product for sleep, and I think it's a little easy because there is really only one that gets used today. It's called Prometrium, and I know they throw that a lot now for sleep in women, even if they don't really need it. It's good sleep. So now that we're going to put someone on hormones, what are my options? What are your options in the clinic? You have a woman that's hormonally challenged, needs estrogen, needs all that. What are your options? Say, let's go with the easy one, progesterone. What can we do with progesterone?
Oh, so progesterone's pretty easy. It's oral, and it's 100 or 200 milligrams, and we usually give it at night. Tell them to take it at night because it does help with sleep.
Yeah.
That's an easy one. And then, like I discussed earlier, the estrogen.
Yeah.
There's several ways you can to get that. The topical are a little more difficult just because it's really depends on how well your skin absorbs.
And that would be the gels or cream.
That is, yes, and that's the same for testosterone. You can also do a gel or a cream. Mm-hmm. It's just your levels are going to vary from day to day anyway, mm-hmm. but it really depends on how well your skin absorbs with the topical.
Yeah, and I know you have talked to me before that you really do prefer the patches, the classic, Vibel, and they have, Estroderm. There's a lot of preparations,
right. And some women disagree with that only because, they may come off if you're in water a lot, and you don't really notice it because it's really small until one day you're extremely aggravated or having hot flashes, and you notice really quick then. So some people do prefer the pellets over that.
Yeah, and I know, that you're, certified in pellets as well, so if that's an option for people if they really want to go there. The other group of people that kind of like fall into the limbo, is these people that are perimenopausal. These are women who are still having kind of irregular periods, but they're suffering immensely with hot flashes, night sweats, mood dysfunction, all the classic signs of menopause. What do these women have anything?
They do, and you can usually control a lot of that with a very low dose birth control. So, and that usually that will get rid of a lot of their symptoms.
Yeah, I think that's fair. So we talked about testosterone a little earlier. I think this is maybe the more controversial of the hormones that would be replaced. So I know when we get labs, I look at these as well as you do. It's amazing to me, seriously amazing, how low these numbers are. Normal testosterone would run between 90 and 110. I would say these women all come in under 15.
Yes, or lower.
Yeah, or lower,
yes.
None. So again, just to little flashback, what kind of things are women experiencing because they have no testosterone?
So the low sex drive, the abdominal fat, like I said earlier, is a huge one that, they never had an issue with it. And then over the last year, they've all of a sudden started storing fat in the abdominal area.
Can't get rid of it.
Right. The muscle mass is a big one also.
Yeah, I hear that.
Hair loss is really big.
Yeah, bigger than I would think. I know I sent a lot of women to a local physician who's a hair guy, and there's this whole regimen of things they do with hair, but testosterone replacement really does tend to help with that. I think maybe at this point I would say, so the ovaries really aren't the problem here. It's really the adrenal gland that's the problem.
With the testosterone?
Yes.
So some women have that long before they even are in menopause or perimenopause.
Yeah, that adrenal fatigue thing that everybody talks about, which everybody's burnout today.
Yeah.
I mean, you're working 2 jobs, you've got 2 kids, all that kind of thing. So currently, are there any FDA-approved testosterone?
There's not.
That's too bad, isn't it?
No. There's a lot of controversy over it, but I feel it's coming.
Yeah, I do too. I think you're sort of like you said earlier. You're limited to using gels. They have nasal sprays, pellets. Of course, is the easy way to replace this, and
injections.
And injections are a little tougher because the doses have to be so much lower than
for
men.
women versus men, right?
Now, do you know? Are there any long-term studies with women using testosterone?
No. There's not very many long.
Right. I think everything's been very short. There's a few out there.
More recent.
Yeah, I think I saw there was 2, but they were really, really short in duration. But I think,
and in general, there's not a lot of studies on hormone replacement. Period. Right.
Way more on men than on women. But I think what I read in the 2 trials that were done, there was no increased risk of cancer. And there was no increased risk of any other medical problems. So it looks like testosterone is relatively safe in women. I think there's a few side effects you can get from it.
If there are in very increased doses for an extended amount of time, the acne, you could get a lot of the acne, and
you have to shave every day.
A lot of extra hair growth, but those we do not see in the office.
No,
you would have to go extremely high and for a long period of time.
Yeah, we're talking levels. I think even in one of the trials with pellets, women had levels of 300, which is actually just out there.
Yes.
Yeah, most of the time you're coming in around 90 to 100.
And we're following up with labs
that's right.
routinely. So.
That's right. So after the discussion, I guess what the things we would like people to take away from this, and I would say for me, the number one thing is to recognize that the Women's Health Initiative was essentially incorrect, and there really is no increased risk of dying from breast cancer.
Right.
And so why suffer unnecessarily? And what else would you say?
Find a provider. If you are a female, my goodness, the ages range from so much wider than what we were ever taught. Now they're saying even as young as 35,
Yeah, I've seen a few sad young women.
Right. So find a provider that has experience with HRT.
Get the hormones.
You don't have to suffer, right?
Yeah, I think the other thing I would like people to know is you have a lot of options for treatment. Like you said, you're a fan of the patches. I think if if that doesn't suit you because you think they're going to fall off, you can always take a pill. You can use a gel.
And some people, the pellets are a little more consistent, whereas the patch, you're going to have quite a bit of
variation.
Yeah,
I think that's it. And then I think you had mentioned that you really should follow up lab. I think what we look at is, that follicle stimulating hormone. I would say most of the women that hit the door are 90, 100, 110, and you really want to push that down to 35. That means you're getting enough estrogen replacement. What else would you say?
Just pretty much to realize when things are changing, sometimes they're really subtle, and just to know that you don't have to continue, to feel that way unnecessarily. There are options, and especially don't not do it or prolong treatment because of fear.
Yeah, unfounded fear.
That's
unfounded fear. And then I think just summarizing, I would say, recognize that some of your symptoms may be testosterone. I think a lot of women struggle with the hair loss, with the weight gain, the no energy, of course, no libido. That's a big problem. Creates marital issues, and that you have a lot of options on testosterone replacement. So, I guess the takeaway is
just find a great provider, that's has experience with hormone replacement, and just know you don't have to continue to sweep it under the rug, as I believe women's health has been for many years.
Yeah, I agree with that.
It's something we have a lot of women that come in that they're treated for depression, as well as other things that just aren't what's going on with
Ash.
Yep. So just find it.
Yeah, so I think it was a good topic. I think Tilia is like one of the people that do it well. Her clinic down in Monroe, Norris Medical, does a great job. She has a partner down there. And I just want to thank everyone for tuning in tonight. And at the end, I have to read this, and it's the context of this and all my podcasts are not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. These podcasts do not constitute any doctor-patient relationship. Good evening from the Longevity Lounge. Have a good evening.